Hello class, and welcome to This Week in Health Psychology. This week we will be exploring pain and the sensations of pain and the psychological aspects of pain. So what is pain? Well, pain seems to have an obvious function. Pain provides constant feedback about the body. It enables us to make adjustments to how we sit or we sleep. Pain is often a warning sign that something is wrong and results in protective behavior such as avoiding moving in a particular way or lifting heavy objects. Pain also triggers help-seeking behavior and is a common reason for patients visiting their doctor. Pain also has psychological consequences and can generate fear and anxiety. From an evolutionary perspective, therefore, pain is a sign that action is needed. It functions to generate change, either in the form of seeking help or avoiding activity. However, pain is not that simple. Some pain seems to have no underlying cause and functions to hinder rather than help a person to carry on their daily lives. Such pain has a strong psychological component. So researchers differentiate between acute pain and chronic pain. Acute pain is defined as pain that lasts for 6 months or less. It usually has a definable cause and is mostly treated with painkillers. A broken leg or a surgical wound is an example of acute pain. In contrast, chronic pain lasts for longer than 6 months and can be either benign, in that it varies in severity, or progressive, in that it gradually gets worse. Chronic lower back pain is often described as chronic benign pain, whereas illnesses such as rheumatoid arthritis result in chronic progressive pain. Now, early models of pain describe pain within a biomedical framework as an automatic response to an external factor. René Descartes, for example, perhaps one of the earliest writers on pain, regarded pain as a response to a painful stimulus. He described a direct pathway from the source of the pain, so for example a burnt finger, to an area of the brain that detects the painful sensation. Von Frey, in 1895, developed the Specificity theory of pain, which again reflected this very simple stimulus response model. He suggested that there are specific sensory receptors which transmit touch, warmth, and pain, and that each receptor was sensitive to specific stimulation. This model was similar to that described by Descartes in that the link between the cause of pain and the brain was seen as direct and automatic. In a similar vein, Goldschneider in the 1920s developed a further model of pain called the pattern theory. He suggested that nerve impulse patterns determine the degree of pain, and that messages from the damaged area were sent directly to the brain via these nerve impulses. So, these three models of pain overall describe pain as having some common features. Tissue damage causes the sensation of pain. Psychology is involved in these models of pain only as a consequence of pain. So, for example, anxiety or fear or depression. Psychology has no causal influence according to these old models. Pain is an automatic response to an external stimulus. There is no interpretation or moderation. The pain sensation has a single cause, and pain was categorized into being either psychogenic pain or organic pain. Psychogenic pain was considered to be all in the patient's mind and was a label given to pain with no organic basis, at least not any basis that could be found. And organic pain was regarded as being real pain and was the label given to pain when some clear injury could be seen. Now, the early simple models of pain, as I've mentioned, had no role for psychology really. However, psychology came to play an important part in understanding pain within the 20th century. And this was based on several observations. First, it was observed that medical treatments for pain, so for example drugs or surgery, were, in the main, only useful for treating acute pain and pain with a short duration. Such treatments were fairly ineffective for treating chronic pain that lasts for a long time. And this suggested that there must be something else involved in the pain sensation which was not included in the simple stimulus response models. It was also observed that individuals with the same degree of tissue damage differed in their reports of painful sensation or painful responses. So Beecher in 1956 observed soldiers' and civilians' requests for pain relief in a hospital during the Second World War. He reported that although soldiers and civilians often showed the same degree of injury, 80% of the civilians requested medication, whereas only 25% of the soldiers did. He suggested that this reflected a role for the meaning of the injury in the experience of pain. For soldiers, the injury had a positive meaning as it indicated that their war was over. This meaning mediated the pain experience. The third observation was phantom limb pain. The majority of amputees tend to feel pain in an absent limb. This pain can actually get worse after the amputation and continues even after complete healing. Sometimes the pain feels as if it's spreading and is often described as a hand being clenched with the nails digging into the palm when the hand is actually missing, or the bottom of the foot being forced into the ankle when the foot is missing. Phantom limb pain has no peripheral physical basis because the limb is obviously missing. In addition, not everybody feels phantom limb pain, and those who do not experience it to the same extent. Further, even individuals who are born with missing limbs sometimes report phantom limb pain. So these observations, therefore, suggest variation between individuals. Perhaps this variation indicates a role for psychology, and so that has become part of the basis for exploring psychology. Now, there's a popular theory known as the gate theory for pain. So Melzack and Wall, from the 1960s through to the 1980s, developed the gate theory of pain, which represented an attempt to introduce psychology into the understanding of pain. They suggested that although pain could still be understood in terms of stimulus response pathways, this pathway was complex and mediated by a network of interacting processes. Therefore, the gate control theory integrated psychology into the traditional biomedical model of pain, and not only described a role for physiological causes and interventions, but also allowed for psychological causes and interventions. So one of the things is input to the gate. So Melzack and Wall suggested that a gate exists at the spinal cord level, which receives input from the following sources: peripheral nerves, So the site of injury, for example, the hand, sends information about pain, pressure, or heat to the gate. There's a descending central influences from the brain. The brain sends information related to the psychological state of the individual to the gate. This may reflect the individual's behavioral state. So, for example, attention, focus on the source of the pain, emotional state, anxiety, fear, depression, and previous experiences or self-efficacy. I've experienced this pain before, and I know that it will go away, in terms of dealing with the pain. And that there are large and small fibers, and these fibers constitute part of the physiological input of pain perception. Output from the gate. So the gate integrates all of this information from these different sources and produces an output. And this output from the gate sends the information to an action system, which results in the perception of pain. Now, when we look at the role of psychology in pain, there are several different levels to it. There's a behavioral level, an affective level, a cognitive level. So we'll take a look at some of those. And one of the things we're going to do is look at the role of learning in pain perception. So researchers suggest that classical conditioning may have an effect on the perception of pain. As described by theories of associative learning, an individual may associate a particular environment with the experience of pain. For example, if an individual associates the dentist with pain due to past experiences, the pain perception may be enhanced when attending the dentist due to this expectation. In addition, because of the association between these two factors, the individual may experience increased anxiety when attending the dentist, which may also increase pain. Now, Jamner and Tursky examined the effect of presenting migraine sufferers with words associated with pain. They found that this presentation increased both anxiety and pain perception, and concluded that the words caused a change in mood, which caused a change in the subject's perception of pain. Then there's also the operant conditioning side of pain, where researchers suggest that there is also a role of operant conditioning in pain perception. Individuals may respond to pain by showing pain behavior, resting, grimacing, limping, staying off work, and such pain behavior may be positively reinforced. Sympathy, attention, time off work again, which may itself increase pain perception. Then there's the role of affect. Some researchers, when looking at anxiety, have explored how patients worry about their pain. For example, Eccleston asked 34 male and female chronic pain patients to describe their experience of pain over a 7-day period. The results showed that the patients reported both pain-related and non-pain-related worry, that these two forms of worry then were qualitatively different. In particular, worry about chronic pain was seen as more difficult to dismiss, more distracting, more attention-grabbing, more intrusive, more distressing, and less pleasant than non-pain-related worry. And other researchers has explored how worry and anxiety play in pain perception. Researchers have examined the relationship between anxiety and acute and chronic pain. They reported that anxiety has a different relationship to these two types of pain. In terms of acute pain, pain increases anxiety. The successful treatment for the pain then decreases the pain, which subsequently decreases the anxiety. This can then cause a further decrease in pain. Therefore, because of the relative ease with which acute pain can be treated, anxiety relates to this pain perception in terms of a cycle of pain reduction. However, the pattern is different for chronic pain. Because treatment has very little effect on chronic pain, this increases anxiety, which can further increase pain. Therefore, in terms of the relationship between anxiety and chronic pain, there is a cycle of pain increase. Then there's the role of cognitions. So a person, the way they think can impact their perception of pain. So catastrophizing. So patients with pain, particularly chronic pain, in line with many other patients, often show catastrophizing. And researchers describe catastrophizing as involving three components. First off, rumination, a focus on threatening information, both internal and external. So, for example, I can feel my neck click whenever I move it. Second, magnification, overestimating the extent of the threat. My bones are crumbling and I'm going to be paralyzed. And third, helplessness, underestimating personal and broader resources that might mitigate the danger and disastrous consequences. So feelings like nobody understands how to fix the problem, nobody hears or realizes that I can't bear this pain. And this catastrophizing has been linked to both the onset of pain and the development of longer-term pain problems. Then we come to the meaning. Now, although at first glance any pain would seem to be only negative in its meaning, research indicates that pain can have a range of meanings to different people. For example, the pain experienced during childbirth, although intense, is a very clear cause and consequence. If the same kind of pain were to happen outside of childbirth, then it would be a totally different meaning and would probably be experienced in a very different way. Beecher suggests, in that previous study that I mentioned, in his study of soldiers and civilians requesting for medication, was one of the first people to examine this and ask that question. What does pain mean to the individual? And Beecher argued that differences in pain perception were related to the meaning of pain for the individual. In Beecher's study, the soldiers benefited from their pain. This has also been described in terms of secondary gains, whereby the pain may be viewed as a positive reward for the individual. One might think of an elite athlete that chooses the painful discomfort of training or of a minor injury in the overall scheme of their success. Then there's self-efficacy. Some research has emphasized the role of self-efficacy in pain perception and reduction. Some researchers suggest that increased pain self-efficacy may be an important factor in determining the degree of pain perception. In addition, the concept of pain locus of control has been developed to emphasize the role of individual cognitions in pain perception. Then there's attention. So there's also been research exploring the impact of attention on pain. Much work shows that attention to the pain can exacerbate the pain, whereas distraction can reduce the pain experience. For example, in experimental studies described by James, illustrated that association using the cold pressor task. Eccleston, in his research, has carried out work in this area and suggests that overall, the better the distraction, the less the pain experience. And this is borne out in hypnosis treatments of pain. And hypnosis is essentially a form of mental focusing and relaxation. And when the mind is focused on something and the body is relaxed, then the pain is reduced. And that ties us into the other areas of psychology and pain treatment. So research shows that psychology is involved in the perception of pain in terms of factors such as learning, anxiety, worry, fear, catastrophizing, meaning, and attention. And multidisciplinary pain clinics increasingly place psychological interventions at their core. And there are several methods of pain treatment which reflect an interaction between psychology and the physiological factors. The first one being the Respondent Method. Now, Respondent methods are designed to modify the physiological system directly by reducing muscular tension. So examples are relaxation methods, which aim to decrease anxiety and stress, and consequently to decrease pain and biofeedback, which is used to enable the individual to exert voluntary control over their bodily functions. This biofeedback training aims to decrease anxiety and tension, and therefore to decrease pain. However, some research indicates that it adds nothing to relaxation methods. Hypnosis is also used as a means to relax the individual. It seems to be one of the most useful for acute pain and for repeated painful procedures such as burn dressings. Then there is cognitive methods. A cognitive approach to pain treatment focuses on the individual's thoughts about pain and aims to modify cognitions that may be exacerbating their pain experience. So techniques used include attention diversion, so encouraging the individual not to focus on the pain, imagery, encouraging the individual to have positive, pleasant thoughts, and the modification of maladaptive thoughts by the use of Socratic questioning. So Socratic questioning challenges the individual to try to understand their automatic thoughts and involve questions such as, what evidence do you have to support your thoughts? And how would someone else view this situation? And in this way, the therapist can use role play and role reversal to help to change the cognitive methods of the individual. And then there is the behavioral side, the behavioral methods. And some treatment approaches draw upon the basic principles of operant conditioning and use reinforcement to encourage the individual to change their behavior. For example, if a chronic pain patient has stopped activities that they believe may exacerbate their pain, the therapist will incrementally encourage them to become increasingly more active. And each change in behavior will be rewarded by the therapist, and new exercises will be developed and agreed to encourage the patient to move towards their preset goal. The three components, therefore, of psychological therapy are often integrated, and we can simply call this cognitive behavioral treatment or a cognitive behavioral treatment package for pain. So when we look at the outcomes of pain treatment and management, one of the key things is to work towards oftentimes pain acceptance, because pain is simply a part of life. The psychological treatment of pain includes respondent, cognitive, and behavioral methods, as we've already mentioned. And these are mostly used in conjunction with pharmacological treatments involving analgesics and anesthetics. And the outcome of all of these interventions has traditionally been assessed in terms of a reduction in pain intensity and pain perception. So recently, however, some researchers have been calling for a shift in focus towards pain acceptance. So Risden is one of those researchers who asked 30 participants to describe their pain using a Q factor analysis. This method encourages the participant to describe their experiences in a way that enables the researcher to derive a factor structure. And from their analysis, the author argued that the acceptance of pain involves 8 factors. And these were taking control, living day by day, acknowledging limitations, empowerment, acceptance, accepting loss of self, a belief that there is more to life than pain, a philosophy of not fighting battles that cannot be won, and spiritual strength. In addition, the author suggested that there are some factors that reflect 3 underlying beliefs. First, we should acknowledge that a cure for pain is unlikely. Second, a shift of focus away from pain to non-pain aspects of life. And third, a resistance to any suggestion that pain is a sign of personal weakness. Now, in a further study, McCracken and Eccleston explored the relationship between pain acceptance, coping with pain, and a range of pain-related outcomes in 230 chronic pain patients. The results show that pain acceptance was a better predictor than coping with pain adjustment variables such as pain intensity, disability, depression, and anxiety. So authors of these studies suggest that the extent of pain acceptance may relate to the changes in an individual's sense of self and how their pain can be incorporated into their lives and into their self-identity. In addition, they argued that the concept of pain acceptance may be an important way forward for pain research, particularly given the nature of chronic pain. So, those are some aspects of pain that involve psychology, and I hope you enjoyed this week's lecture in health psychology, and I hope to see you next week. You take care. Bye-bye.